Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review of Croup for general pediatricians. Croup, also known as viral laryngotracheobronchitis, is one of the most common causes of acute upper airway obstruction in young children and a frequent reason for emergency department visits, especially during the fall and winter months. We will walk through 10 carefully designed clinical scenarios covering clinical presentation, physical examination, pathophysiology, diagnostic workup, differential diagnosis, severity classification, treatment with corticosteroids and epinephrine, complications and discharge criteria. Let us begin. Question 1. Clinical presentation. A 2-year-old male presents with a 2-day history of rhinorrhea and low-grade fever. Tonight, he abruptly developed a seal-like barking cough and noisy breathing. On examination, he is non-toxic but has audible inspiratory stridor when agitated. What is the most likely diagnosis? Option A. Acute epiglottitis. Option B. Viral croup, also called laryngotracheobronchitis. Option C. Foreign body aspiration. Option D. Bacterial tracheitis. The correct answer is option B, viral croup. Croup typically begins with 12 to 72 hours of non-specific upper respiratory infection symptoms, such as rhinorrhea and low-grade fever. The hallmark barking cough and inspiratory stridor usually develop abruptly and often worsen at night, which is a classic feature parents will describe. The viral etiology, most commonly parainfluenza virus type 1, causes subglottic inflammation and narrowing, which produces the characteristic steeple sign on imaging and the typical sound of stridor. Unlike epiglottitis, the child remains non-toxic and continues to swallow secretions, and unlike foreign body aspiration, the onset is preceded by viral upper respiratory symptoms rather than a sudden choking event. Question 2. Physical examination. During the examination of a 3-year-old with suspected croup, which of the following physical examination findings is most indicative of severe upper airway obstruction? Option A. Barking cough during crying. Option B. Inspiratory stridor only when agitated. Option C. Biphasic stridor occurring during both inspiration and expiration at rest. Option D. Low-grade fever at 38.2 degrees Celsius. The correct answer is option C, biphasic stridor at rest. Stridor at rest, especially when it becomes biphasic, indicates significant narrowing of the subglottic airway and signals severe disease. Severe croup typically presents with prominent stridor, marked suprasternal and intercostal retractions, decreased air entry, and the child may appear anxious, agitated, or drowsy. A particularly ominous sign that every clinician must recognize is quiet stridor in a distressed, exhausted child, which means airflow has become so minimal that the obstruction can no longer generate audible turbulence. This is a red flag for impending respiratory failure and demands immediate airway intervention rather than reassurance. Question 3. Pathophysiology. A 15-month-old presents with recurrent episodes of sudden onset barking cough and stridor at night that resolve quickly with exposure to cool air. There is no preceding fever or upper respiratory infection symptoms. What is the most likely diagnosis? Option A. Spasmodic croup. Option B. Laryngomalacia. Option C. Bronchial asthma. Option D. Gastroesophageal reflux disease. The correct answer is option A. Spasmodic croup, also known as allergic croup. Spasmodic croup features an abrupt onset at night, a short duration of only minutes to hours, and the absence of any fever or upper respiratory prodrome. It often recurs and is frequently associated with a personal or family history of atopy and allergies. The pathophysiology involves sudden subglottic edema or spasm without the significant viral inflammation seen in classic viral croup. Distinguishing it from viral croup matters because spasmodic episodes typically resolve very quickly with exposure to cool, humid air, and the recurrent nature should prompt evaluation for underlying atopy and parental education about home management. Question 4. Diagnostic workup. A 2-year-old presents with classic croup symptoms. He is stable with mild retractions. What is the most appropriate next step in the diagnostic workup? Option A. Urgent lateral neck X-ray. Option B. Nasopharyngeal swab for viral polymerase chain reaction. Option C. Clinical diagnosis and severity assessment. Option D. Arterial blood gas analysis. The correct answer is option C, clinical diagnosis and severity assessment. Croup is primarily a clinical diagnosis based on the history and physical examination findings. routine imaging and laboratory tests are not recommended because they offer little additional information and can increase patient agitation, which actually worsens airway obstruction. The Westley Croup score is a validated tool that uses 5 clinical features: stridor, retractions, air entry, cyanosis, and level of consciousness to classify severity. A score of 0 to 2 indicates mild croup, 3 to 7 indicates moderate croup, and 8 to 17 indicates severe croup. This scoring system, or simply clinical gestalt, guides management decisions and disposition. Question 5. Differential diagnosis. A 4-year-old presents with high fever at 40 degrees Celsius, drooling, and a tripod position. He has no barking cough. Which diagnosis must be ruled out immediately? Option A, viral croup. Option B, peritonsillar abscess. Option C, acute epiglottitis. Option D, retropharyngeal abscess. The correct answer is option C, acute epiglottitis. Epiglottitis is a true medical emergency, and key distinguishing features include high fever, prominent drooling, dysphagia, and the absence of the classic barking cough. The child characteristically adopts the tripod position, leaning forward on the hands with the neck extended to maintain airway patency. The incidence of epiglottitis has decreased dramatically since the introduction of the Haemophilus influenzae type B vaccine, but it remains a critical differential diagnosis for any child with stridor and toxic appearance. Management requires immediate airway stabilization by the most experienced personnel available, typically anesthesia and otolaryngology, in a controlled environment such as the operating room, and you must not agitate the child or attempt visualization with a tongue depressor. Question 6. Severity classification. A child with croup has frequent barking cough, audible stridor at rest, and moderate intercostal retractions, but is not agitated. How would you classify the severity of this case? Option A, mild. Option B, severe. Option C, impending respiratory failure. Option D, moderate. The correct answer is option D, moderate croup. Moderate croup is characterized by stridor at rest, visible retractions, and frequent barking cough, but with little distress or agitation, which is exactly the presentation in this case. For comparison, mild croup presents with occasional cough, no stridor at rest, and mild or no retractions. Severe croup features prominent stridor, marked retractions, and significant agitation or distress, and impending respiratory failure presents with decreased level of consciousness, fatigue, cyanosis, and paradoxically diminished stridor. Accurate severity classification is essential because it directly determines the choice of treatment, whether dexamethasone alone is enough or whether nebulized epinephrine and admission are also required. Question 7. Treatment with corticosteroids. For a 10-month-old with mild croup, presenting with occasional cough and no stridor at rest, what is the recommended pharmacological treatment? Option A, oral dexamethasone single dose. Option B, nebulized budesonide for 3 days. Option C, oral prednisolone for 5 days. Option D, supportive care only with no steroids. The correct answer is option A, a single dose of oral dexamethasone. Dexamethasone is recommended for all children with croup regardless of severity, including mild cases. A single dose at 0.15 to 0.6 milligrams per kilogram has been shown to reduce symptom severity, reduce return visits to the emergency department, and decrease hospitalization rates. Oral administration is preferred because it is non-invasive, well tolerated by children, and is just as effective as the intramuscular or intravenous routes. The maximum single dose is 16 milligrams. The long half-life of dexamethasone, around 36 to 54 hours, makes a single dose sufficient to cover the typical course of the illness. Question 8. Treatment with epinephrine. A 2-year-old with moderate croup has persistent stridor at rest and significant retractions despite receiving dexamethasone. What is the next best step? Option A, repeat dose of dexamethasone. Option B, start intravenous antibiotics. Option C, immediate intubation. Option D, nebulized racemic epinephrine. The correct answer